Association session in the AIOS2025, and I'm Dr. Mohan Rajan, past president of TNOA. I'm the chairman, and along with me is the co-chairman, Dr. Sriram Gopal, who is the secretary of the Tamil Nadu Ophthalmic Association, and then we'll be having Dr. Nirmal Frederick, also the past president, and he'll be joining us very shortly. And we have the first speaker, and who is none other than Dr. Sujata Mohan, who is also the president-elect of the Tamil Nadu Ophthalmic Association. And he'll be talking to us on surgical management of eye drops. Am I right? Keratoconus. Surgical management of keratoconus. Sorry.
She's actually going to speak on updates and management of
surgical
management of keratoconus.
Change the topic. Yes.
So good afternoon, everybody.
Mike.
Good afternoon, everybody. Is it audible? Okay. At the outset, I'd like to thank AIOS and TNOA for giving us this opportunity. My topic is on surgical management of keratoconus. So indications for surgical intervention would be patients with very advanced keratoconus, extremely thin corneas, patients who are intolerant to contact lenses, poor visual acuity with glasses, unmet visual requirements and expectations, patients with severity and progression of keratoconus, location of the cone, and the presence of scarring or a previous eye drops. So surgeries for keratoconus are very many, but we're going to go through one by one. So this case one was a patient with advanced keratoconus, and what I'm doing here is I'm trying to identify how much the cone is extending by putting some fluorescein, and then now I'm measuring the cone so that I can decide what will be the trephine size. And in this case particularly, we had to take an 8.5 millimeter trephine to encompass the cone. And after making an initial cut, I'm just making a small cut, and now I'm using a 30 gauge needle to inject air into the stroma to get the big bubble. So now I'm decompressing the anterior chamber. This is very important. Otherwise, when you're de-roofing the bubble, the chances of upthrust and the Descemet's membrane getting ruptured is very high. So you can see that the air is escaping, and now viscoelastic is injected into the space between the stroma and the Descemet's. And using a blunt varnish, we make 4 quadrants and cut the superficial layers to expose the Descemet's. So at this point, it's very important that to make sure that the bubble is extended up to the area where you have done the trephination. If not, you have to be very careful, because that's a point where you can inadvertently perforate the Descemet's. So now you can go all round and remove all the areas which have been separated, and now you can get a nice exposure of Descemet's membrane. And at the same time, making sure that you're going along the area where you already made the trephination, so that you'll keep to the exact size of the trephine that you have chosen. And once you have done this, you also have to make sure that there is enough area for you to suture. So use a second instrument and just make a small dent, so that it will give you some idea where to suture. So this is a slightly oversized graft, of 0.25 millimeter oversized graft, and I'm using 16 interrupted sutures to complete the case. So in cases with advanced keratoconus, sometimes a big bubble may not be possible. In this situation, that we may have to do a manual DALC, or sometimes even convert it into a PK. So this is a post-op of the same patient, and these patients do extremely well because of volume building, and also because the quality of vision goes up, and they might need a selective suture removal if the sutural astigmatism is very high. The next case I'm going to talk to you is about a keratoconus with inferior cone. As you can see that the patient has a cylinder of 3.75, but topographically is almost 6 diopters. And similar, you can see topographically a astigmatism of 4 cylinder. So in this case, we decided to go ahead with a CARES, or a corneal allogenic intrastromal ring segment, which is basically a volume building procedure, and it acts like a belt and compresses the cone. So it gives some amount of refractive effect also, and reduces the amount of astigmatism and gives more symmetry to the central area of the cornea. So here the trephine size we have used is 6.5 to 8 millimeters to create this double trephine. Allows us to make the CARES segment. And the femtochannel dimensions are 4.6 inner diameter and 7.1 outer diameter. And the depth of the cornea is about half the thickness plus 50 microns, which is around 300 microns. So this is how the femtosecond channel is being created. This is a femtosecond laser. You can see that the channels are larger than what we would normally do for an intact segment, and it has also created the incision. Incision is usually made at 0-180, and I'm using a wide spatula to open out the channels that we have created, and also using a trypan blue marker to know till what area that we have to introduce the segments. So, and then the segment which is already been prepared, which is de-epithelialized as well as endothelium has been removed, is inserted into the channel which has been created, and the excess is trimmed off. You can alternately also make another incision in the opposite side with the femtosecond itself, and you can even pull through instead of pushing through. Sometimes if you have a large segment, you might have to do it, and keep pushing so that you make sure that the segment comes up to the area where we plan to do the case. That is somewhere between 4.5 to 8.5 clock hours. So this is a post-op of the same patient. You can see the patient landed up with a +1 cylinder, and in both preoperative K1 and K2 showed a drop in cylinder of at least 3.5 to 3.8 diopters. And this is a comparison map done at 1 month and at 3 months, showing an excellent response to CARES. This is the AIOS2025 showing the presence of the CARES segment. The next patient I'm going to discuss about is a patient who underwent intacs. So this patient had a mean spherical equivalent which was very high, which was 4.5 and 7.5 cylinder. So in these cases, it's always better to go for 2 segments, one inferiorly as well as one superiorly. And the incision is usually made in the steepest area of the cornea, contrary to what we do in CARES. In CARES, only an inferior segment is placed. There's no superior segment placed, whereas in patients who are undergoing intacs with high mean spherical equivalent, we do place 2 segments. And in this case, we plan to place a symmetric 0.5 segments with an incision at 130. And this is how an intacs is done, and 2 segments are being placed. The first segment goes in quite easily, whereas the second segment, because already some space has been occupied by the first segment, may be a little bit tight, but it is still a doable procedure. And what happens is when you it produces what we call as a reduction of the arc. So the arc shortening effect is how the intacs work, and thereby they produce some amount of symmetry in the central portion of the cornea. All these patients have to be counseled that whatever we do, they still may have to wear spectacles or contact lens. And after this, you can continue this with the collagen cross-linking. So these are some of the results. This is the patient which I showed you, 7.5 cell has dropped down to 4.5. This is again the next patient who had an asymmetric segment, and the cylinder dropped from -4 to 1.5. Here you can see that the amount of the comparison map showing a difference between the A and B, showing the amount of correction that is there. So the other surgical indication for in keratoconus is a management of acute hydrops. Normally, acute hydrops is managed only medically, but in cases of very advanced hydrops, we plan to do a compression suture. Here, an inferior PI is created, and air is injected into the anterior chamber to tamponade, and 10-0 nylon suture is used to create the compression suture. Usually the suture starts at the clear cornea, that is the area between where the hydrops is to the clear zone, and you apply multiple sutures. It need not go through and through, it can just go even partial thickness. The advantage is that when you put a compression suture, the stroma is made more compact and makes it much more easier for the Descemet's membrane to come back to its original position. And in the long term, this also prepares the eye to receive the keratoplasty earlier. Unfortunately, if you just leave it like this, it takes quite a long time for the edema to resolve and makes the patient very uncomfortable. As you can see here, the edema is resolved and the Descemet's is back in its position. So the compression sutures work, like I told you, as full thickness, can be partial thickness, compresses the stroma and helps in fluid absorption, shortens the edge of the DM tear, helps in earlier resolution of the edema, prevents corneal neovascularization, and prepares the eye for early surgery. So this is a case of keratoglobus which came to us about 2 years back, and you can see the map had a thinness Pachy of 203. Though we advised DALC at that point, patient was not willing. But subsequently, 2 years later, she came with this presentation. She was complaining of watering and irritation in the eyes, and you can see that on doing a CDLS, there's an area of perforation with a micro leak. So the cornea has become so thin it started perforating, and the keratoglobus was from limbus to limbus, and she underwent a full thickness penetrating keratoplasty with the limbus to limbus graft. And her uncorrected visual acuity improved from 636 to 612. So this again, the last case I'm going to show you is a case of PMD, or pellucid marginal degeneration. There are different surgical modalities which have been suggested. One of the latest is that is of a tuck-in lamellar keratoplasty, where a full thickness penetrating keratoplasty or a DALC can be done, but it is tucked into the, a groove is made all around, and it is tucked into the groove. The reason being that prevents the stem cells being removed because of the full thickness, full amount of the limbus being destroyed. So even in this case, though we have done this, you can still see an area of persistent epithelial defect, which we had to deal with using autologous serum, and finally he healed only with lateral tarsography. So summarizing, surgical options should be considered after non-invasive management such as specialized contact lenses. Intakes and cares are good options for moderate keratoconus. There are several stromal augmentation procedures which are becoming very popular, like basement membrane transplants. And in patients with advanced cone and extremely thin corneas, DALC is the best option. PK can also be considered in patients with dense scars and post-hydrops. And ectatic conditions such as PMD, keratoglobus need specialized procedures with increased skill levels. Thank you.
Thank you so much, madam. It's a very wide range of amazing and exhorting surgeries. For somebody who doesn't see corneal surgeries regularly, it was really an eye-opener. Thank you so much, ma'am.
Any questions from the audience regarding how to manage keratoconus surgically?
Actually, I have a very fundamental doubt, ma'am. The first case you showed, DALC, you said you gave us a few instructions so that we can avoid a small perforation of the thing. In case you perforate, what would you do?
It's a small perforation. It's a small perforation. You can continue to
No, mic
It's
is
not
working.
audible.
No.
both are equally bad.
Yeah.
Okay, if it's a small perforation, we can continue to we can put in air and continue gently all round and suture it. Usually, if you take care, what happens is nothing will happen. Otherwise, you can go for a double anterior chamber because the aqueous can go into the interface. So that is one problem. But if you have a very small break, even a moderate size break, we can still continue because it's important that we retain the Descemet's membrane of the patient, because in the long run, that is more beneficial to the patient.
Thank you. Any other questions? Anybody?
Yeah. Go to Murli Arika next.
Yeah.
Yeah.
Yeah, you can.
Yeah, thank you, Sujata, for the wonderful talk on the surgical management of keratoconus, which is very, very important in the current scenario. And we have Dr. Murli Ariga with us, and he's an authority on glaucoma and one of the top members of the Tamil Nadu Ophthalmic Association. And Murli will be talking to us. What's the topic, Murli?
What's new in glaucoma management?
What's new in glaucoma medication? Okay. Can you set the timer for 8 minutes? 8 minutes, bas.
Thank you, TNOA and AIOS for this opportunity. And there's a lot to say in the medical management of glaucoma, and what's new and what are the current perspectives and how to escalate management in terms of medical management for glaucoma is the talk today. So we all know that glaucoma is managed by reducing intraocular pressure, and how do we decide what medication, how much to do and how much to give a given patient is to categorize the severity of glaucoma, categorize the risk, set a target pressure for a given eye of a given patient, and then choose the medication. So how do we choose the medication? You go for a higher target when the damage is early, when the life expectancy is short, and the damage that occurred is high. Similarly, we lower the target when there's advanced damage and life expectancy young patients, and when the IOP at which the damage occurred is low. So all of these helps us decide as to tailoring a target to a given patient. And we have to keep in mind various aspects of glaucoma management, that is the tolerability of the drug, the long-term IOP efficacy, the cost, the adherence. Will the patient follow something like pilocarpine given 4 times a day or prostaglandin given once a day, and so on. Long-term efficacy, long-term safety, and how does the drug work? I mean, in the sense, if you're giving a drug which is going to work 20% lowering of IOP as compared to what can work at 35% lowering of IOP, all this has to be in mind when you're deciding the target pressure. First-line drugs commonly have been, like in the past, beta blockers. Now we all moved to prostaglandin as the choice. Every patient almost gets a prostaglandin now. We sometimes give a beta blocker for some issues other than when the prostaglandin cannot be prescribed for some reason. Second line drugs include, if you're given a PGA, you add a beta blocker. You also have alpha agonists, topical CA inhibitors, pilocarpine. Now the new kid on the block is the ROCK inhibitors. Fixed combinations are very convenient for most patients because about 1/2 of our glaucoma patients, one drug is not enough. So we need to give more than one drug. So we need to add a drug, and giving additional drug as an adjunct is also convenient to have 2 drugs in the same bottle. So convenience of dosing with a single bottle obviously improves compliance, adherence, and decreases the risk of washout when you put multiple medication. The back or the preservative in the medication reduces when you're giving a combination. Decreases allergy rate, decreases the hyperemia if you're giving bromonidine with timolol, for example. The hyperemia rate is much less. And also we must remember that almost all of them have timolol. So whenever you can't give timolol, you have to reconsider the combination itself. And dosing compromise is a disadvantage because suppose you want to give timolol twice and a beta blocker and the prostaglandin once, we are going to give a combination with the prostaglandin and timolol, you're giving it only once. So there's a dosing compromise, and some believe that timolol doesn't work at night. So dosing compromise is there, which is why some countries have not approved prostaglandin timolol combination in even the US, for example. So currently available fixed combinations include the prostaglandin with timolol, pilocarpine, dorzolamide, brimonidine. You also have a beta-free brimonidine brinzolamide, which doesn't have a beta blocker. And we now have the world's first triple drug. Triple drug is beta blocker, brimonidine, brinzolamide combination, which has actually become very popular now. We are quite surprised at the logic and the way we thought it would or would not work. But you do find it's extremely useful in practice. It hugely improves compliance, particularly, and then the IOP lowering efficacy is fantastic. So we get 30-35% drop in the IOP. And of course, we have the Rho kinase inhibitors with timolol. I think the one in India that's available is ripasudil with timolol. The triple combination, many publications, including a multicenter open label phase 3 trial in India, has shown the IOP lowering anywhere between 35 to 50% lowering intraocular pressure with one single drug. And this is a winner because we really been enjoying the benefit of not giving 3 bottles to a patient, 2 bottles to a patient. And this particular company, I think, has revolutionized the world's first triple combination, at least available now in India. And ROCK inhibitors reduce the intraocular pressure by increasing the aqueous humor outflow through the trabecular meshwork primarily. And we have ripasudil, netasudil, and various combinations also. And they are basically serine, threonine protein kinases expressed in the trabecular meshwork. And the ROCK inhibition decreases the actin-myosin-driven cellular contraction and thereby reduces the production of the fibrotic ECM proteins, which alters permeability of the Schlemm's canal endothelial cells and morphology of trabecular meshwork cells. For all those of you who want to know the pathophysiology, how it works. So in simple terminology, it improves outflow through the trabecular meshwork. It's a trabecular outflow drug. And besides the increase in the aqueous outflow and decrease in the intraocular pressure, it is also said to have a role in neuroprotection. It helps in patients who have undergone glaucoma filtering surgery. Any bleb fibrosis, I generally prefer to give a drug like ROCK inhibitor, in which tenon fibrosis is reduced in somebody who is getting fibrotic blebs. I would prefer to give a ROCK inhibitor. And similarly, there is some advantage of giving these kind of drugs in patients with corneal problems because the endothelial cell density sort of improves with the use of the ROCK inhibitor. So you have multiple mechanisms of action, multiple utilities in terms of a glaucoma patient, especially in people with corneal problems. I would prefer and lean towards these kind of, rather than giving a CA inhibitor, I would probably give a ripasudil, netasudil kind of drug. The mean IOP lowering was about 5.5 in phase 2, phase 3 trials with both netasudil once daily and ripasudil twice daily. But mind you, the ripasural and etasural kind of drugs are never given as first line drugs, usually second line, third line drugs. By the time you already decided on operating on this patient and going in for a surgical procedure. So generally they are third line and maybe in fourth line drugs. The more number of drugs you add to medication in glaucoma management, you will find the efficacy of a single drug given alone is different from a third and a fourth drug added on to a pile of already existing drugs. So the efficacy tends to drop. You won't really get a huge drop in IOP if you're giving, let us say, more than 3 drugs or 4 drugs. So it's usually never more than 2 bottles, maybe 2 or 3 combinations at the most. 2 bottles or more is the limit for medication in glaucoma management. Beyond that, you should think of SLT, think of some other surgical management, go for a mixed procedure or go in for trabeculectomy and so on. There's so many options now available. So beyond 2 bottles, no. And this is a problem with netasural in particular. Ripasural also, invariably you end up with these hyperemia and perilimbal hemorrhages. You also start seeing these kind of things in the honeycombing in the cornea, which is reversible when you stop it, of course. But again, this is a worry. Once this happens, you cannot continue these drugs for this patient. And the new, again, what's available in India is a completely PF, preservative-free medication. This is also new. This is a big advantage for many patients. We also have 2 technologies in the PF bottles which are now available. One is called as the Novelia bottle. The other one is Aptar Pharmacy makes these Aptar bottles. I think Cipla makes Aptar. Many other companies use the Novelia formulations. They are very nice and very useful. The benefits of PF glaucoma therapy being preventing ocular surface inflammation, reducing side effect of preservatives, increasing adherence, and of course improves patient's quality of life and ocular discomfort. So all of these advantages of PF. And moving on to what's new again in glaucoma medication. These are the ones which were there in the past. I think some of us who are older generation glaucoma practitioners would have heard of this pilocarpine insert called OcuCert. This is all quiz questions for PGs who are here. But we don't use this anymore. We have now the newer formulations which can come in as a punctal insert, come in as silicone rings where you can implant bimetoprost, give travoprost in a implant which is kept into the punctum and so on. This is new, this is FDA approved, and this is a bimetoprost implant. This is actually a small pellet like thing. People who have seen Ozurdex, this is similar to the Ozurdex kind of implant in which you actually implant it into the anterior chamber. And it's first approved by the FDA a few years ago. Biodegradable polymer designed to release bimetoprost over a 3-month period. So what happens after 3 months? Can you inject it again? We don't really know because the approval is only for 1 injection. We don't know how many more injections we can give. What's going to the patient happen to the patient subsequently? This is a video which is available on the YouTube. It's just how the injection is given into the anterior chamber. In the interest of time, I'll move on to the last slide here. This is called as the, for people who have heard about the eye stent, you know how what is called as the eye dose. The eye dose is actually similar to the eye stent. You stent the trabecular meshwork like this. You put in the drug elutes from the stent which is kept here. This is made by the same company which makes the eye stent. It's called the eye dose. You have a travoprost which can come through the drug. So it's a titanium implant and elutes the drug with a therapeutic window of about 6 months. So issues to resolve with all of these implants, cost and availability, it's going to be a huge cost. Injection related complications, you're going to inject into the anterior chamber or in the angle, cataracts, endothelial issues, corneal problems. What about multiple medication? Can you just give 1 drug alone? What about repeat injection? So many questions that come up to mind. So you have to understand that we are making a paradigm shift in the way we are delivering drugs to the eye, choice of the drugs which you are giving to the patient, preservative-free combinations, and drug delivery systems are also changing. So would we shift away from glaucoma drops? We have to wait and see. Thank you all.
Thank you, Murli, for a wonderful, really wonderful talk. I just have a couple of questions. One is this, I think Duresta is very costly. I was told it is about $15,000 US.
Very expensive, yes sir.
Very expensive. So it's not, it's out of the
it's out of reach for most of us and our patients.
Definitely, and it works only for 3 months or 6 months, whatever.
It's not approved for second and third injections.
Second thing is, how do you know that the patient is, so you have a patient right in front of you and the glaucoma is progressing. Okay, how do you know the patient is using the drops properly, whether compliance is good? Is there any way to check? Or you feel it progressing, you want to keep on adding one more drop, or says something else for the patient?
I think it's a fantastic question, and that's a dilemma which all of us would face as practitioners, ophthalmology, general ophthalmology, glaucoma, and otherwise. Glaucoma, we face it much more. The problem is how we try to check whether the patient is so-called adherent, and the new term for that is called adherence rather than compliance.
Yes.
So we want, if you are given a bottle which is to be used once a day, another bottle twice a day, and say come after 3 months, the patient will use one bottle only for both eyes for the next 6 months and not turn up after a year.
Correct.
So how do we check that? We casually ask the patient, how many bottles have you bought? How many times have you used the medication? Can we see your bottles? We see the bottle, you'll know how many times, how dirty it looks, or the cap is not there, or how many bottles have they purchased, any proof of some kind of purchase. We ask the relatives casually, have you seen them using the drops? Do they use it correctly or not? And then of course we look at the pattern of field loss, we look at the intraocular pressure, and we decide, we can make out from, a lot of guesswork involved, and intuition and guesswork in regarding whether the patient is using it or not. If we strongly suspect that compliance adherence is a big issue, we simply switch to a surgical method. We offer a surgery rather than challenging the patient, confronting the patient, and saying the patient that you have not done this correctly, and they're not likely to, once you know this is a non-adherent patient, it's not likely to listen to you further. Offer a surgical solution. We now immediately opt for either an SLT or offer a MIGS as the surgical solution.
You still believe that the maximum medical therapy, 3 drug, 4 drug, nowadays I
Maximum
think 5
therapy.
drugs also is there. But I'm asking you because instead of pushing the patient and it's only going to benefit only the pharma companies, why don't we advise surgery for this patient
The
much
entire
earlier?
shift, the treatment in glaucoma is shifting towards early management, early intervention in glaucoma. It's no longer wait for medication, wait for progression, then do offer SLT, then offer surgery and so on. We straight away target glaucoma as a surgical disease. When you see cataract, we don't say, I'll give you some eye drops, come back after 6 months. So glaucoma also is slowly turning into a disease or a disease where you can offer SLT as a first choice. Patient does not opt for it, we offer medication. That's what I do now. We offer SLT. Then you have the choice of adding medication or giving medication. The patient does not want SLT. And if you find a minimum cataract or cataract which is operable, not the cataracts which we think or imagine there is cataract, when there is real cataract, you think of doing the cataract surgery and probably combine it with a mixed procedure. Mixed procedures work the best for mild and moderate glaucomas. So increasingly we offer MIGS as mild to moderate glaucomas with cataract surgery, and increasingly offer this maximum medication is usually never more than 2 bottles. Most people cannot use more than 2 bottles, at the most 3 or 4 medications, not more than that. That too in the interim period while you plan some other intervention.
Yeah, but one good thing is, right now, you're able to give 4 medications across 2 bottles.
Yes.
Things have
correct. That's why the combinations, the fixed combinations are
so
a real
maximum medical therapy is actually just 2 bottles, 3 doses, 1 BD and 1
How
OD.
is the efficacy?
Efficacy is good.
For example, the Trisopt,
Trisopt
good.
efficacy is fantastic. In fact, we were surprised with the results of the drug which was coming in.
I can fully
we
agree
were
with that.
surprised that why it was working so well. Then we found that most people who are given multiple bottles and giving separate bottles didn't work as well as the combination purely because of compliance.
Only.
No, especially when I additive
Exactly.
effect,
Additive
and I've
effect,
seen
yeah.
my
Compliance is the main key factor here.
probably one of the most refractory glaucomas is neovascular.
Yes.
So neovascular glaucomas, I feel if Trisopt doesn't work, invariably I know this patient is going to end up
Yes.
needing surgery.
Yes.
That is how I take it.
Correct.
If I can bring the pressure down to at least 20s by
Anti-VEGF.
Trisopt, anti-VEGF, laser,
PRP,
he might be
anti-VEGF,
better. But if he doesn't,
Trisopt.
I tell him after anti-VEGF and laser, you'll end up needing a shunt. That's how I go.
Absolutely.
And nice to know that you people are also going to join us in injecting regularly in the eye.
No, that. Yeah, any questions from the audience on glaucoma? Glaucoma, I think, what about the direct SLT? If you have any experience, direct SLT has coming.
The Belkin's transscleral non-contact
Transscleral, direct
SLT is
SLT.
available now. It came from Israel. I think we're all awaiting the introduction in India. I think it may change the way we manage.
It's not new.
We have that
It's been
now.
there for a long time.
We have that now.
ECP is there for quite some time.
No, there's a new avatar in the sense we start doing it from the front of the eye. It's in the scope under the purview of our anterior segment. Make a limbal incision, inflate the posterior chamber, view it's a single function probe. It's a light source, viewing endoscope with a laser delivery. I'm doing it for the last 1 month now.
But
We have
only
it for a
in
demo.
pseudophakic eyes you can do that.
You can do it pseudophakic, you can do it aphakic, and you can do it wherever vitrectomy is
Phakic also?
Phakic we generally avoid.
That's what.
Phakic you cannot.
Phakic you can't do.
Phakic, you will be touching the lens. No, ma'am. Actually, for cataract with glaucoma surgery, especially angle closure, the indication and publications have been on phaco with ECP. It's called endocyclophotocoagulation. What it does is it shrinks the ciliary process. You are likely to open up the angle further than you would normally do with any other cyclophotocoagulation procedure. Endocyclo is controlled. You can
Control.
actually
This
see-
one is
You can
this
see the
patient
burn,
is-
ma'am.
see ciliary processes, and you can do 180 or 270. I have started doing 180. Now last week I did about 2 patients, 270. IOP response has been fair. So I am
And
in
it
the learning
open-
curve.
Because it pulls the ciliary body
Instead
back,
of a
it opens
diode
up
which
the
is
angle
done-
also.
Diode which is done blind,
Yes.
you actually see ciliary processes. I think the pars plana route has been popular among retinal surgeons for quite some time. But now it comes under the purview of our retinal surgeons, anti-segment surgeons also.
Okay, we'll go to the next speaker, who is the star of TNOA. Sriram, you just introduced him.
A man who needs no introduction. He is probably a synonym of quality in India, especially in eye care. Dr. Nirmal Frederick, a past president of TNOA. He'll be talking to us about key performance indicators in cataract surgery.
Thank you, Chairman, and thank you, Sriram, for the kind words. Good afternoon, friends. So this is my topic, key performance indicators in cataract surgery, one of the commonest surgery done not only in India, but also worldwide. So this is the power of data. So when we keep moving, we always keep a watch on the dashboard to see where we are going and how fast we are going. The same way, we need certain parameters to know where we are going and how we are going to reach that area. So you would have heard of this keyword from Indigo, probably one of the, probably only one airline now who is working in India, on time, every time. So how do they arrive at this figure? And they have enough data, and they have submitted that data to DGCA, and that has been accepted, and now they are allowed to use this statement on time, every time. This is exactly based on the data they have given, comparing with the other domestic airlines. And same way, this is the largest network, and they claim officially the fastest network. Again, the reason is based on numbers, and this number is called key performance indicator. So many industries, particularly the service industries, use this indicator to their advantage, not only for branding, but also improving their quality parameters. So what is this KPI, key performance indicator? Is a measurable value, so that demonstrate how a hospital or organization is achieving a key objective. So basically, we compare KPIs with a lighthouse. So these key performance indicators for surgery, they guide the surgeons through the practice variations. If you see cataract surgery results, it varies between the neophytes as well as experienced and expert surgeons from private practice to NGO hospitals. And same way, adverse outcomes. This again determines the basic KPI, and both provide standardized signals to navigate safely. So the important aspect of KPI is safety, improvement, and also to know where we stand and to prevent adverse outcomes. Right, so we all know cataract surgery is the common surgical procedure, and modern healthcare demands measurable quality assurance. Maybe in the next few months, all your insurance companies and payers will be asking about what is your outcome indicators, and balance of clinical outcome and patient experience is the new key performance indicators. So any objective, we need certain quantifiable metrics to determine the quality and outcomes. So there comes the importance of these numbers. And these are the driving forces, patient expectation. Now all of us know that patients tend to see Google review and give more value to that review than a doctor's long-standing branding or image. And value-based reimbursement replacing volume-based. So far, we've been paid based on numbers, but now we might be shifted to payment based on outcomes, and also professional self-regulation. Now NMC is coming out with so many new regulations that our outcome parameters will also be useful for the next review of our licensing. and also identification of outliers needing support or remediation. So in case a surgeon fails to reach a particular outcome, so he may be called for further training. So these are the common indicators we use, time for initial amount assessment, and these are certain numerical and denominators that really help us to know where our institution or the department stands. And how do we measure surgical success? So many outcome parameters are there. Visual acuity outcome. So some hospital keep it as 612 or better, some hospital keep as 69 or better. And also refractive outcome, whether there is a cylinder with a target within 0.5. And also the rate of complication is again outcome indicator. And PCO rates, few hospitals taken up this as a benchmark for their lens optimization. And surgical efficiency metrics, so previously phaco time was one of the metrics, but now we don't really go and see that. And the outcome indicators, which is really important and many of the licensing agencies use, is the rate of infectious endophthalmitis following intraocular surgery. This is yet another outcome indicators. Apart from this, now the new age indicator is the patient reported experience measures or the patient reported outcome measures. So patient come with certain complaints, so there may be 5 complaints or 8 complaints, and so if we ask them post surgery, we would have addressed only one complaint of them, that is the visual acuity. But unfortunately, patient doesn't care for the numbers we care for, that is 6.6 or 6.5. For him or her, the overall satisfaction with the entire care experience is more important. The quality of counseling and communication given by our optoms and counselors are very important. The physical comfort that they pass through during the operative period is important, and emotional support addressing their concern, both financial and non-financial concerns, are very important. So the net promoter score here would be whether you would recommend our service to family or friends. So basically we need to go beyond these clinical measures and use certain other instruments like CATQuest or VQual, which are nothing but the names for the questionnaires, and see or ask for the functional improvement for daily activities, independence measure from active patients in terms of driving, reading, face recognition, etc., and also need for spectacle post surgery. So apart from the regular KPI, these are the things that are going to be important in the future. So this is a sample study done at our center, and we published the results, patient reported outcome measures in cataract surgery. It's nothing to do with our Snellen based 6.6 or 6.5. This is basically based on checking the effectiveness of quality assurance, as well as the objective indicators here are beyond visual acuity, that is contrast sensitivity, color vision, and the visual parameters that helps in patients' day-to-day activities. So I will not go into the details of the research methodology. Basically, if you want to have a key performance indicator defined, so you need to have the objectives defined, have a standardized data collection, and have a minimum sample size, and account for the exclusion inclusion criteria, and plan for continuous activity. So what we have done is a sample of 1 month reports based on this questionnaire CATQuest 9SF, and basically 2 categories: the symptoms from the patients and the patient activities and lifestyle. We collected the data in the form of a Google form and graded according to the patient difficulties, and these were the findings. So in 1 month, say 45 patients, so this is the patient requirement, and what really surprised us was the numbers. So the 87% were completely satisfied about the outcome based on their activities, except for a few patients who had dry eye or diabetic macular edema. So the conclusion is 87% were happy in all aspects of vision, quantity and quality wise, and 96% were satisfied when there is spectacle-free vision after cataract surgery, and that is the reason why we went on to adopt trifocal or EDOF lenses for many of our patients. And so these were the recommendations based on that particular month, and the impact of audit for patients and impact of audit for hospital is patient reported outcome measures is very important, and it's going to be the new key performance indicator for many of our activities. So this is how it is planned. So closing the loop, so if you want to improve your quality of services, you need to use KPI for improvement. and also compare the benchmark with other hospitals based on anonymized data. The companies will or accreditation agency will be using these indicators for benchmarking our country's requirement. So implement, review, keep learning from the KPI and celebrate the success. So not everything that counts can be counted, but what's really counted, literally count in terms of patient satisfaction and experience. Thank you so much.
Thank you, Dr. Nirmal, for wonderfully encapsulating what all you need to look for. Cataract surgery, as far as we are concerned, is a surgery, and probably for a long, long time we only thought of one result, which was what was the vision, corrected or uncorrected. But as you said, it is an experience. You have to be on the other side and realize it's actually an experience which the patient undergoes. And there was one slide where you had talked about things other than endophthalmitis and vision and stuff. So patient, his experience, how comfortable he was, how much he was apprehensive, or did he feel pain, not feel pain. These things are all something which are totally ignored. And the last point in that slide was whether you'd really recommend this to others. So that is a result. So that one slide probably encapsulated what all for all these young people out there. When you're going and starting your practice, that is probably the only thing which matters ultimately. Doesn't matter what machine you have, what surgery you do, anything. Only thing which matters is every patient walking out, whether he'll refer another patient. So thank you so much, sir. Anybody has any doubts? Murali sir?
Thank you,
I think applying quality standards to outcomes in whatever procedures we do, I think it's a very important aspect of practice. It's not just visual outcome, it's not just intraocular pressure results, or it's not just the retina being on. I think these parameters are very important as we go on in our practices, and we'll find that increasingly auditing, especially quality audits, are very, very important.
No, it can be used to improve ourselves. Our quality of, see, basically we concentrate on the surgeon's parameters. But unfortunately, 90% of the time, the patients are with the staff because their orientation is totally different. So this is what these type of indicators will catch up, and that will help the organization also.
I learned something, KPI.
Thank you.
Absolutely. We learned a lot of things.
Thank you. Thank you so much, sir. So yes, like what Dr. Nirmal said, 20/20 vision alone doesn't guarantee a good result.
Yeah.
But well, you tried your best. He reads 20/20, you mentioned he's comfortable, but still he's unhappy. Because happiness ultimately is a state of mind. So when some people choose to be unhappy, in spite of doing everything right, what do? That is what Dr. Mohan Rajan is going to talk about. He's going to talk about a patient having 20/20 post-op, but still unhappy. How do you approach this?
Thank you, Sriram. Thank you, Nirmal, Murali, and all the members of the Tamil Nadu Ophthalmic Association for giving this wonderful opportunity, all the delegates who are gathered here. I think it's very important and appropriate that I am following this topic after Nirmal, because he has talked about what are the quality assurances which are very, very necessary, or key performance indicators which are very necessary. Let's see what we are missing as far as 20/20. We are able to get this 6/6 vision for all these patients nowadays. It's not a big deal, but something else is happening. The sun is setting on the old mindset of cataract surgery. The old mindset is we have typically a very dense cataract, old patient, 80 plus, coming into your clinic with 3/60 or 6/60 vision. So this is the golden triangle: premium IOLs, premium surgeon, and the premium surgery. And we need to make sure that you consistently hit the bullseye. The new mindset is very, 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 very important. That is, new mindset is like a luxury consumer. It's like a plastic surgery patient. He's coming with 6/9, 6/6 vision. You're not able to drive at night. He's got decrease in the contrast sensitivity, quality of vision, and all these problems can occur. And these patients, their expectations are also going up. So how many of you had these patients like this? 6/6, 20/20 patients, they're unhappy. They take the life out of you. Am I right or not? Okay. Can I have a show of hands? How many of you? I'm sure many of you. If you have not seen it, you will see it in the future. Because this is one of the major problems, changing profile of the cataract patient. And they are hugely aware. The expectations are very huge. They are highly demanding lifestyle changes. They think they know everything. I'll just give you two examples. Music master Ilayaraja. Okay, you know about him. And yes, Indian cricketer Kapil Dev, everybody knows about him. I operated Ilayaraja in 2007. At that time, we put Restore +4 lens for him. And Kapil Dev was operated in Delhi. He was also, both of them Restore plus 4D. Okay. What is this thing? At that time only, this only multifocal was available. Okay. So this is a bifocal lens. So now Ilayaraja is finding it difficult to use the keyboard or the harmonium. Okay. Because that is the intermediate distance for him. And Kapil Dev is now playing a lot of golf. He is now having difficulty in putting. So what is the problem? The multifocals these are bifocal lenses. These bifocal lenses means they work for distance and they work for 33 or 35 centimeters. Intermediate is not there. The range of vision is not there. So what is this multifocal or bifocal lenses meant for housewives, house husbands and mother-in-laws. Okay. And these are new generation IOLs which are coming. So all these new generation, the EDOF lenses, the good intermediate vision they are able to give. Because the new this thing is, for example, where I am using my laptop, where I am using my iPhone, okay, your phone, it's about 60 centimeters, 50 to 60 centimeters from the eye. Reading a newspaper in 2010, guy is reading a newspaper because he is reading a hard copy of the newspaper, okay, that's 35 centimeters. Reading a newspaper in 2022, he is reading a newspaper not on the newspaper, he is reading a newspaper on the tab, on the iPad. So automatically the distance goes, so the near point has actually receded from 35 centimeters to 60 centimeters. If you take the newspaper sales of Chennai, okay, in Hindu and Times of India, everything has gone down. Because people are now reading newspapers not on the newspaper hard copy, but they are reading on the, so the intermediate vision, we call it the new middle. So this is a refractive multifocal. I'm going to take you quickly through some case scenarios. Refractive multifocal, vision 6.5. I operated this patient way back in 2003-4, I think. The rezoom lenses, I don't know how many of you are aware of these lenses. Rezoom lenses, at that time it was made by a company called AMO, and subsequently became J&J. And these are refractive multifocal lenses. Very good lens. Only problem is you can see the rexis is as good as the femto rexis. 6.5 N6, patient not happy. Why? Because the halos, the photic phenomenon. Okay, halos around the starbursts, around the headlight and significant glare. Okay. And this patient actually was she was a type C personality, but once she started seeing the halos and glare, she became a type A personality. Okay, and this is the problem. When you have glare, it can be very bothersome if somebody can see. This is refractive multifocal. Of course, with newer trifocal lenses, it's much, much less. This patient sued me. Okay, at that time, I got really scared. Fortunately for me, she died of myocardial infarction 6 months later. So I'm just saying, this is again another patient, 55-year-old female, EDOF lenses. Okay. EDOF lens 6.9 N6 vision. Patient not happy. Problem, what is the problem? The problem is, okay, can you see something there on the lens? Right. Ask your assistant not to hold the optic of the lens with any forceps or anything, whether it's a unifocal or a multifocal. Okay, I thought it's just a scratch on the lens and left it like that. I should have actually removed, but there is a crack on the lens. Okay, this patient went to another person in Madras city, Chennai city, and that fellow said, you got two cracks. One is a crack on the lens, another is a crack as a surgeon who operated on you. So this patient also became very furious. So this again very, very important. Okay, especially multifocal restore lens complains of misty vision. So this is a problem with this Acrisoft IQ platform. Hope the Alcon guys are not here. When they have glistenings on the lens, glistenings are subsurface nano glistenings. These glistenings on a monofocal lens it may not affect, but on a multifocal lens already the contrast is reduced by to 25%. On top of that, glistenings can affect significantly. So again, a 60-year-old female patient, 6.6 N6 patient complains of decrease in the contrast, and you can see the slit lamp. You can see here there are only lines on the posterior capsule. There is only a wrinkle on the posterior capsule. Okay, you don't have to wait for the posterior capsule opacification. In a monofocal lens, in a multifocal lens, even a line or a wrinkle on the posterior capsule can significantly drop the visual quality and contrast vision for these patients. Okay, so we need to yak them much earlier than normal. You can see just a line or a wrinkle on the posterior capsule, and you can see here how it is, the wrinkles which are there, and once you yak them, the patient becomes all right. Again, you can see another patient not happy. What is the thing? You see the fundus is normal, 6.6 vision. Patient typically tells you, okay, that immediately after the surgery I was able to see well. For past 1 or 2 days I am not able to see well. After a couple of weeks, okay, if you see the anterior segment, everything fundus normal. But if you do OCT, okay, how many of you have do OCT for all these patients pre-operatively and post-operatively as well? Please put your money on OCT put your money on a good optical biometer, put your money on a good operation microscope. These three things. Don't buy Mercedes or Audi. Okay, buy all these three things are very, very important. The OCT picked up the CME and the patient became all right once you put the patient onto steroids and non-steroidal anti-inflammatory. Again, a patient with right eye, left eye, you can see here multifocal thickness, residual astigmatism. Okay, you can't have residual astigmatism. Nowadays, we have every formula, every patient, you take the IOL biasing and you feed it in the Barrett toric calculator. Any which is against the rule of astigmatism. Anything even about 0.75, 0.8 against the rule of astigmatism. Against the rule means the horizontal meridian is steeper than the vertical meridian. If you take 100 people in the population, 85 to 90% will have against the rule of astigmatism. You need to overcorrect them. So go for a toric lens for these patients. So obviously we didn't go for a toric lens, the patient became unhappy. You can see another patient, you can see a thickness multifocal lens, perfectly done surgery, no problem at all, 24.5 diopter. You can see what's happening, postoperative refraction. Okay, plus 2.5 in the right eye, plus 2 in the left eye, postoperative refraction. Okay, if you make them myopic, they will only cut your head. If you make them hyperopic, they will cut and bury you. Simply I will tell you, because if you make them hyperopic, the problem is, if you make them hypermetropic, they are not able to see distance, they are not able to see near, they are not able to see intermediate also. Okay, they become very unhappy, and this patient also became very easy. But what is the reason for this? Dense asteroid hyalosis. This patient, I did an OCT, I do OCT for all my patients. OCT was perfectly normal. You can say dense asteroid hyalosis in both eyes. The dense asteroid hyalosis alters this refractive index of the eye. So I discussed with Samuel Mascott and Warren Hill and Bobby Osher, everybody. We didn't know because what is happening. You can see this is a problem. So when you have dense asteroidosis, probably you have to be a little more careful about the thing and not probably put a multifocal lens for these patients. Again, you can see crystal lens, quickly go through it because the crystal lens is an accommodating lens. I used to use a lot of lenses way back in 2009, 10, 11 and suddenly this lens can move forward and it's called the Z syndrome. And this is again a patient with a capsular phimosis. When you have capsular phimosis, the lens can move back. When the lens moves forward, there can be a myopic shift of the eye, of the refraction. And when the lens moves backward, there can be a hyperopic shift. So once you do a capsulotomy, YAG laser capsulotomy, again ocular surface is something which we neglect. Okay, straight away when a patient comes, you straight away take the slit lamp and look for any cataract. But look at the ocular surface, look at the lid margin disease. Optimize the ocular surface before you deal with these patients. Maybe the lubricants and ointments for this MGD, because MGD is not only for the unhappy patient, but also MGD is a high risk for lid margin, high risk for endophthalmitis as well. You have to be very, very careful about it. So, because a lot of organisms can be there in the lid margin, which can go into the anterior chamber during the surgery, and this can happen. Again, symphony lens, patient, she is a gynecologist, very happy, 6'5" and 6. And first time she told me, a gynecologist, she is able to differentiate between ureter and uterus. Okay, normally they get confused. When they do a hysterectomy, they take the ureter also, but she is very happy. But what is the problem? This is the negative dysphotopsia. Negative dysphotopsia is because of the anterior the retina, which is on the nasal side, getting reflected into the temporal space. We do not know, many people do not know why it's occurring. It occurs only if there is a perfectly done surgery. So negative dysphotopsia is very, very difficult to treat. And what we do is, sometimes you can ask the patient to wait for 3 months, 6 months, or after 6 months, what to do? We give them some other problem. Okay, so that they'll forget about this negative dysphotopsia. So something which is functional also. So quickly I'm going through this, and both eyes cataract surgery done within 1 month, and I think I overshot the time. Yeah, we can take another. Okay, yeah. This again you can see a PSC cataract, steroid induced cataract, and my Meenakshi has come. She can give a talk, and can see this. So, what is the problem? The synergy lens I put 6.6 and 6. Patient not happy. Why? Not happy. You can see fundus is normal pre-operatively. I forgot to do a OCT for this patient. You can see what is this? Vitreomacular traction. And that is why I'm telling, do a OCT. Do a OCT. OCT, put your money on OCT is perfect. Because sometimes in a dense cataract, you'll not be able to see the macula properly. You can miss subtle ERMs and OCT and all on the macular holes and all these things. So all these things I think are very, very important. Look at the angle alpha. Quickly I'm going through since Meenakshi has come. And again, you can see this is one of my associates who left a lens which has got only one haptic. Okay, you can obviously leave like this. Okay, and we had to go in and explant this lens, cut this lens and take it out and put another multifocal. Okay, so you can just see on the table you decide what to do and how to handle. One thing which I want to tell you is when a patient is unhappy, always look for residual refractive error, PCO, CME, do a OCT. Clinically, you may not be able to see that CME. Dry eye, ocular surface, decreased contrast, look for glistenings, higher order aberrations on the cornea, lens tilt, decentration, functional overlay also. When you have a patient who is unhappy, always look for and tell your staff, tell your security person to bring the patient straight away into your chamber. Okay? And make sure that you finish off the patient within a few minutes and escort the patient straight away out. Okay? Because if he is going to sit there in front of among the other patients in the OP, he will screw up the other patients as well. Am I right or not? Okay? So this is a message I wanted to give you. Thank you again for the wonderful opportunity, the patient attention, and any questions from the audience I would like to take.
Thank you. Thank you so much, sir. Especially the last 2 lines of advice is very well taken.
Yeah.
Just had one doubt. What is your cutoff for against rule astigmatism for multifocals?
Anything above 0.75,
Yeah, because
I do.
Sometimes with the online Barrett, it suggests a toric even for 0.4,
0.4, yeah, that's what I'm telling you.
You
You need to put all your formulas in your Barrett toric calculator. And against the rule, it will tell you even 0.3, 0.4, it will tell you go for a T1, a T2 lens or something like that.
But would you do that? That is my question.
I will do that. 100% I will do. 100% I will do. What do you mean?
So, some questions?
Yeah. No, I think Dr. Meenakshi has come.
Yeah, okay.
You want to ask any question?
Okay. So till Dr. Meenakshi sets up her presentation, Mohan sir, how do you select the brand for the VIP patients? Because most of them, they do a thorough study and come.
Yeah.
And when we tell one type of lens, they'll confront or ask for a different, or they would have asked for second opinion and they suggest those.
No, I do a math. I do the counseling myself. I don't leave it to the counselors. I do a math myself and find out exactly, because the chat time is something which is very important. Do everything pre-operatively. Don't do anything post-operatively. Pre-operatively, you have to spend a lot of time with the patients. What exactly is the visual requirement of the patient? Whether the patient is just wanting vision for distance and reading, and I will go for a trifocal. If the patient say, no, I'm doing a lot of driving, then push them to EDOF lenses. So like that. The patient says, no, I don't want even anything, I don't mind occasional glasses for reading, then I go in for the enhanced monofocal lenses. So like that, I broadly divide them, but it's important that you talk to them personally, because unless you talk to them, because the patient is going to relate to you, is not going to relate to the counselor post-operatively as well.
And if you think somebody has got very high expectations, would you dissuade them from a higher end lens? Somebody who's very demanding, and because you have that sense that they are going to create an issue later.
Absolutely. I think it's a very important, the type A personalities, you need to make sure how important they are, and you have to tell them what is the realistic expectation. You can't obviously expect them to read a trifocal lens with a candlelight dinner, whatever it is. They cannot be able to order any stock market. This thing, it's not possible. You have to tell them what is realistic from the surgery. I think realistic expectation is something which is very, very important, and tell them. Okay.
Yeah. One more thing is, many of them come with comorbidities, particularly ERM or diabetic macular. Very difficult to satisfy their post-operative requirement.
Yeah.
So when you tell them, how do you really desist from, because they are prepared for a trifocal, whatever the cost.
No, I think you have to tell them. We have to be very clear. You have got a posterior segment problem. There's absolute contraindication for your trifocal lens. Yeah. Tell them. Yes.
Yes.
So they have recently ablation. So all these things, I think these are patients whom we should explore.
Yeah. Yeah, because I didn't have time.
I
Because
have a lot of these retinal
all the refractive
patients who are
surgery
ready
patients
for,
do a topography to find out whether center ablation, or do an eye trace to find out whether any higher abrasions are there in the cornea. So all these are very, very important. So I think we are running out of time.
Yeah, yes.
And Meenakshi is the
last
best
speaker
in
for our session
pediatric
is
ophthalmology.
Dr.
Yeah.
Meenakshi Swaminathan, a well-celebrated pediatric ophthalmologist and teacher to probably scores and scores of postgraduates, and probably I can take the honor of being the only retinal surgeon who's learned some pediatric ophthalmology from her. Welcome, madam, and she's going to talk about current trends in management of progressive myopia.
Current trends in the management of progressive myopia. Thank you so much for the TNOA committee for inviting me to give this talk. Of course, I gave the topic without even realizing what I was saying. So I'll tell you why. Why are we afraid of progressive myopia, or is it myopia progression? So progressive myopia is when myopia becomes degenerative myopia. That's not what we're going to talk about, even though I only gave the topic. We are going to talk about myopia progression. So why is all this fuss going on about myopia control? Because every 1 diopter increase in myopia increases the lifetime risk of myopic maculopathy, and then they have to go to Sriram, by 67%. Okay? So when do we call it progression? Well, the spherical equivalent needs to have increased by equal to more than minus 0.5 diopters per year. What about axial length? Everybody's talking axial length also. Well, before age 10, axial length growth in the emmetropizing children is about 0.1 to 0.2 millimeter per year. How do you know this child is going to become myopic? Because then it starts becoming more than 0.2 millimeter per year. And progressing myopes typically as 0.3 millimeter or more per year. Then you call it progressing myopes. So the key message, if we can keep the myopia below -3 and axial length below 26 millimeter, this is a huge modifying factor for lifelong risk of visual impairment. Then that is our goal. Okay, so you have to understand why this child is myopic. Is it genetics or is it environment? So when we talk of genetics, you have to pay attention to age of onset. How early did the child start wearing glasses? How rapidly is this progressing? And like, for example, these questions have to be asked to the mother or the father, and the father. What age did you start wearing glasses? How rapidly did your refractive error progress? And what was the final refractive error before it became stabilized or you had LASIK? Now, environment, you want to ask the child. How much time is outdoors versus indoors? They generally find children with higher IQ or pushing themselves to study, studying in ICSC, Cambridge board, international board, all these kids, they're more prone to myopia. Urban environment compared to rural environment, and continuous near work. We all used to say, oh, it's all the gadgets, it's all the phones, it's the iPad. No, kids who read good old books hours and hours together are also at risk. Okay, so what you need to do, myopia progression, we have to pay attention. Who is going to progress? Younger age at onset, strong family history, visual environment is terrible because their child never goes out. And then Asian ethnicity, and when I say Asian ethnicity is not really applicable to us, but maybe more in the northeast, people from West Bengal, where there may be some admixture to Asian ethnicity and binocular vision conditions. Okay, so what do we have? What interventions do we have to stop this progression? We can provide advice on environment that includes 2-hour outdoors, take breaks regularly while you're near work, elbow rule. Keep it a little far away, as far away as your elbow, from your elbow. Have important controls over smartphone use and good sleep. Sleep has also been shown, poor sleep has also been shown as an important factor for progression. What do we have for optical and pharmacological? Well, we have these myopia controlling spectacles and low dose atropine. And finally, if despite everything if you are progressing, maybe look for binocular vision anomalies like esophoria or accommodative lag. Okay, so I'm going to illustrate this better with 2 patient examples, just to tell you how much chair time goes into myopia these days. Those days you just fitted glasses. When my father was in ophthalmology practice, he just fitted glasses and just said, come back after a year. So, but this is just it's become so complex now. 8-year-old male child comes with parents, unable to see clearly with the current glasses, wearing myopic spectacle correction given by a local ophthalmologist for the last 2 years. Now, when they started, had difficulty in school copying from the board. Child is in good general health, non-consanguineous marriage, full term, normal delivery, cried soon after birth, normal milestones. Child looks a bit shy, parents look worried, and this is our dialogue. Do either of you wear spectacles now or used to wear in the past? Then the father says, I have never worn glasses, but my wife used to wear glasses, but then underwent LASIK. There's some genetics going on. So I said, what age did you start wearing specs and what was the number? And what was it when you had LASIK? She says, I started specs when I was 10. I started with -2. By the time I had LASIK, it was -5. How about your other children? Well, I have one older child, she's 12 and has started wearing glasses since 3 years, number is -3. So now I conclude from the history that this child has mild to moderate genetic predisposition with one parent, one sibling with myopia. Okay, now I go on to asking environmental history. How much outdoor time does he get per day? The child says 40 minutes of PT in school, twice a week. How about at home? What is the routine after school? Comes home by 3:30, has a wash, eats some tiffin, watches some TV, then goes for chess class. Chess is twice a week, then badminton twice a week. They're very proud. I've put the child in chess class, badminton class. Then from 5 he has Hindi tuition, then he will go down to play with other kids till 7:30. Then he said he will finish dinner, finish other homework and then go to bed. Okay, how much is phone, tab, iPad usage? Not much, but he loves to read. He will always be with a storybook. We have also encouraged him. At least no phone addiction, no. How is his sleep? Oh, he sleeps really well, 8 hours. So I conclude that he does not get much sunlight exposure, excessive near work in the form of books, but good sleep. I summarize the clinical exam. No esophoria, cycloplegic refraction has increased by -1.5. Objective, subjective, everything. Fundus is normal. So is this progression? Progression of myopic refractive error, remember, more than equal -0.5 is progression. Yes, this is progression. Significant progression. So what do we do now? I cannot change the genetic component. So I'm saying, what can I change in the environment? I don't ask them to bring photos of their house for every patient, but I ask them to describe their house. Do you have a window? Do you have a balcony? Do you have sunlight coming in? And this is what they describe to me about their house, that they also have a terrace. So my advice is like this. Morning breakfast is in the balcony. Take him out of chess and badminton because both are indoors. Put him in tennis, swimming or football. We can take him to park, beach or sit in terrace for 2 hours. Reduces book reading to maximum 30 minutes a day when school is in session. Monitor the distance. No lying down and reading. No phones. After 6 months they come back. Refraction is stable. So we have deferred starting other myopia interventions. Do I routinely order axial length before starting treatment? Usually I do, because I want 2 factors. I want something that the parents can see, because objective, subjective, everything is mine, the refraction. But I also want to see an axial length, which is a true objective measure as well. Okay, patient 2 and 3 came together. 8-year-old boy, 9-year-old girl, wearing myopic corrections for 3 years. Every year there is a change in the number. Good health, normal birth history. History of excessive smartphone use during COVID because they started online classes on the phone. Both children showed change of -1.5, -1.25, subjective, objective. Myopia history. Neither parents myopic, not grandparents, not uncles, aunts, cousins. I ask all this. How many kids, siblings do you have? I ask the parents. How many do you have? Do they wear glasses? Do their children wear glasses? Means first cousins. So this is how you have to take history now. So myopia history. I ask them environment. 2 PT periods per week, after school tuitions back to back. There is no place to play. Both parents work and return at 8 p.m. Grandparents watch the children. The children watch 2 hours of smartphone before parents show up, so that the grandparents can watch TV. There is no question of a smart TV. Because sometimes I'll tell them, project it in a smart TV. No, at least they're not sitting with the gadgets. This is their house. Where will they play? Where is the window? Where is the balcony? There is nothing. So my advice is like this. There seems to be no genetic predisposition. I understand that both of you work and it is difficult to expect grandparents to take the children out. I also realize there is no place for the kids to play. But let me explain about the environmental modification. So I tell them a few things about reducing smartphone use, all those things. But I will explain myopia control glasses versus LDA. These parents heard the cost of LDA and they said, no, we will, and the cost of myopia control glasses, they said, no, we'll go with LDA. Okay. So that is what they did. After 6 months, both children's refraction changed, this time only by -0.5, because it's not magic. will slow the progression, eventually stop. The mobile phone users cut down to 1 hour with breaks. They go out for 2 hours on Saturdays and Sundays when the parents are off from work. In conclusion, evaluate how much genetic vulnerability this child has for onset and progression. Capture the child's daily life. Then design the child's daily life. Don't tell them, take him, let him have outdoor for 2 hours. Where will the grandparents take them for 2 hours outdoors? So what we call as motta advice. Don't give motta advice. Design the child's day. Understand the family's challenges in implementing your environmental advice. Judicious choice of myopia control options. Close monitoring with open lines of communication between you or your assistant and the family. Thank you so much and good luck.
Thank you so much, ma'am.
Brilliant talk.
The permission of the chair, if I can use this term, your talk was in very level.
Yeah.
In Tamil.
Yeah.
So, ma'am, I just saw one slide where you said LDA versus myopic control spectacles. So, not that I don't know, living as a pediatric ophthalmologist, I know that there are two different modalities.
Yeah.
And they have definite cutoffs.
Yeah.
You do LDA only in certain age group and certain refractive ranges. Same with myopic spectacles. But off late we see any child, or rather probably not even child, sometimes I even see adults who've been diagnosed to have myopia, who are prescribed LDA and whatever one of those myopic glasses which you talk about. This is very, very disturbing and growing trend of late. I'm sorry.
Right. So I absolutely right. I have parents who have come urgently back 2 days later after my suggesting regular spectacles with environmental modification. Because my worry is if I only give the LDA as the first choice, or the myopia control spectacles as the first choice, or LDA, the environmental modification never happen. So, and we know how powerful the sunlight exposure is in curtailing myopia or slowing the progression. So I never, unless they show clear evidence of progression over the last many visits to some other ophthalmologist. They have clear progression. Then I say, okay, let's start LDA. Otherwise, so I've had parents who will come running back 2 days later. Madam, we went to optical shop. They're told apparently there are special glasses. You didn't even suggest. Looking at you like don't have any knowledge. How come we came to you? Optical shop liye solran. Enna madam neenga sollama vittutinga. You hear all kinds of nightmares.
True.
Okay. So
That's why I asked that.
Yes, absolutely. You're absolutely right. Or people who come with everything. Avial. Put this also, that also. Or panacea for all refractive errors. Plus, minus 0.5 cylinder, a patient is wearing LDA. Okay, anything goes. So, and as an educator, it always goes back to me and my guilt, and I feel, Orunga soliye tarla. We didn't teach them pediatric ophthalmology. We didn't teach them how to manage myopia.
Yeah.
We didn't teach them ophthalmology. We didn't tell, because most of myopia is managed by non-pediatric ophthalmologists. Pediatric ophthalmology hopefully know how to give and what stages to give and all. But the bulk is by non-pediatric ophthalmologists. Right? Myopia should not become pediatric ophthalmology. Ayyo, na adha already paakren. I want to see a few squints here and there. I see only myopia. So I am happy for others to please manage myopia, but solliye kudukalappa. How to do refraction.
Like it's always a potpourri where patient has LDA. I've seen 20-year-olds with LDA and myosmart glasses, and the problem is we have to cut a sorry figure because we don't know what to tell them at all.
But why are these
Meenakshi, I want to ask
so
you.
expensive?
Pardon?
Glasses
Yeah.
These myopia glasses are so expensive.
And how effective it is?
That is the technique. It is effective.
Really
It
effective?
is effective. It is effective. But again, it's not a standalone. If you give
No,
the
you
glasses
take
and they are
other factors also.
Yeah, exactly. Because like I said, I think the environmental modification is a lifestyle change. You need to bring in that lifestyle change and put these things as it cannot be used as a crutch. Now, the potent Kannadi, I'll do anything I want. That cannot be. Aniya parra ni tambi ni iPad parra 4 manaram cannot be the answer.
What is important is the range of refraction and the age of the patient.
Age of the patient, range of refraction, affordability.
Any questions from them?
Yeah.
Any questions? Yes, ma'am. Can you use the mic, madam?
Sometimes the patients with the hypermetropia,
Careful.
they also
somebody
come,
please help
they
them.
also come and they will say कि पर हमारे बाजू में जो रहते हैं उनको कुछ चश्मे का नंबर कम करने के लिए कुछ दिया हुआ है. Then you have to explain that
yeah.
it is your plus lens because for them it is only a glass.
Glass.
Glass, yeah.
So you have to have a good chair time with the, especially
The-
with the pediatric
Absolutely.
parents.
The only person I have, only refractive error I have not seen with these glasses is presbyopia. அவங்களுக்கு தனி சார்ஜஸ் வச்சிருக்காங்க. So
No, that's because there are different costly brands of progressives available.
Correct, that's what I mean.
Generally, they avoid MyoSmart and LDA.
நான் வேற மாதிரி கறக்க வழி இருக்கு. So
Yeah. Anyway, a wonderful talk.
Thank you.
Meenakshi. Very nice. We have come to the end of this session. I would like to thank the Asia Pacific Academy of Ophthalmology and the All India Ophthalmological Society for allotting a separate session for the Tamil Nadu Ophthalmic Association, which is, I think, very, very useful. Though there are only a few delegates, but all the delegates are very, very actively listening and actively participating in the whole process. So I sincerely thank each and every one of you on behalf of the Tamil Nadu Ophthalmic Association, and I request all the speakers and the panelists to come for a group photograph here. I think all of you can come for a group photograph. All of you can come.